to use, let me just see. No, I'm going to go on to sludge. Can you see my slides?
Yes, we can see now.
Perfect. Here, normal amniotic fluid, hyperechogenic. And here, very hyperechogenic amniotic. You can see the umbilical cord, and the amniotic fluid is white. This is particulate matter. The term sludge was coined by us. This is not what we had in mind. I will show you in a moment what we had in mind. So this happened more than 20 years ago. Patients present with premature labor, and they have a very short cervix. This typical patient is contracting. This is, of course, a fetal head, and this is particulate matter. This is what we call amniotic fluid sludge. And particulate matter in amniotic fluid can be due to pus, can be due to vernix, can be due to meconium, or to blood. This is a contribution up here. Now let me tell you, the first when we observed this floating material in the amniotic cavity was in patients with preterm labor. So our first paper was this one. 84 patients with premature labor, 77% didn't have sludge, but 22 had. What happened? The patients who have sludge, the ones that didn't have sludge remain in utero for a long time. Those who had sludge, they live shortly after the amniocentesis. So having sludge was bad for duration of pregnancy. Then they were more likely, the patients with sludge, to have delivery within 48 hours, delivery within 70 days, less than 32 weeks, less than 35 weeks. And also, they were more likely to develop clinical chorioamnionitis, actually 10 times, was not significant, but it's 10 times greater. It's a function of the numbers. They're more likely to have intraamniotic infection diagnosed by amniocentesis, acute histologic chorioamnionitis, suspected neonatal sepsis, and babies were admitted to NICU. And by the way, they were more likely to die, so sludge is important. What is sludge? Well, look at the typical beautiful sludge here. This floating material. We define it as free-floating hyperechogenic material in close proximity to the internal host. And that distinguishes this from other causes of particulate material. Here is how we figure out the first cause of sludge. This is a patient who was going to deliver. We put a needle, she had sludge, we aspirated the sludge, and this is how sludge looks like. It looks like pus. And we looked under the microscope, and there were sheets of white blood cells, so that is the reason why it's pus. Pus is a lot of white blood cells, and in gram stain you can see that it's full of bacteria. This is scanning electron microscopy of sludge. You can see that there are some bacteria, some cocci, but all of this is polymeric substance because, in essence, the bacteria are building around the bacteria to protect themselves against natural antimicrobial peptides that are produced by humans. The most common organisms in sludge are ureaplasma, mycoplasma, GBS, and candida. And here is a biofilm. So a biofilm, you have planktonic bacteria, the ones that you can see individually in a gram stain. Then the bacteria tend to grow, adhere to a surface. Then the bacteria start to grow inside that building and make this cement to protect itself against the water. By the way, this is how the biofilms grow. If you will be surprised to learn that all the tubes, all the plumbing in your homes have biofilms. But this is not a problem if the biofilms are here. But if the biofilms fracture, then you have bacteria that starts going into the water and other things. So biofilms is a way to protect bacteria, but also if the biofilm is encased, induces less of an inflammatory response. Now, what is the evidence that we have biofilms in the amniotic cavity? So this is a sample of amniotic fluid. This is the sludge. This is in situ hybridization for 16S of bacteria. And you can see the bacteria is in the middle. And you have all of this gray thing is polymeric substance protecting the bacteria from the amniotic fluid that has natural antimicrobial peptides, such as the fencing. A few images. This is one of the images that we published many years ago, the three-dimensional image of sludge, and this is one that we're going to publish. This is using silhouette to render sludge of the amniotic cavity. By the way, there are different appearances or the causes of particulate matter. Now, sludge can also be present in asymptomatic patients who are at high risk of return delivery. And if you have sludge in the mid-trimester, in asymptomatic patients, they are more likely to deliver preterm. Also, they are more likely to have preterm prom and to have intraamniotic infection, intraamniotic inflammation, develop clinical chorioamnionitis, and have acute pathologic chorioamnionitis. Importantly, they are more likely to have a fetal inflammatory response. So, sludge is bad. In this, another study showing that ureaplasmas are the most common microorganisms. Look at how infrequent. GPS is not even in this list. Now, babies who are born patients with sludge are more likely to be admitted to intensive care unit, not surprisingly have sepsis, convulsive morbidity, are more likely to die. Now, one way to think about it, take-home message is, if a patient has sludge, even if asymptomatic, more likely to deliver preterm, to deliver preterm prom, to eventually have microbial invasion, acute histologic chorioamnionitis. Now, not everything, every particular matter is infection. Let me give you the typical thing in what happens at term. And I'm going to show you particulate matter in patients who are close to term. Here is the pus, vernix, and the meconium. Here is a patient with bulging membranes who have a hyper-echogenic aggregate matter. This is pus material similar to the one that I showed you before. This patient had candida. Not only the candida was present in culture, but this is congenital infection. This is how vernix looks like. This is typical of the patients who are in late gestation with premature labor, or this is late preterm birth. You can see this layer that is not floating. This layer is a sludge that doesn't have amniotic fluid. Here you have vernix, and here you have only no white blood cells, only epithelial cells. Now, what you are asking, probably a patient want to know, is can we treat sludge? Well, here you have different papers. In the literature, some people claim that you can treat sludge. We have been able to eradicate intraamniotic inflammation once we have diagnosed, even in patients with sludge. We have also been able to eradicate in patients with premature labor and intact membranes, not in preterm prom. Now, I'm going to show you a case that is very illustrative. This is a 39-year-old patient who presents at 29 weeks of gestation and has a short cervix, 0.7 centimeters. And this patient had this particular matter here. We did an amniocentesis. These are normal values. The patient had a negative amniotic fluid gram stain, so no bacteria visible. The glucose should be above 14, normal, and is below 14 indicates inflammation, normal glucose. The white blood cell, 2. The cultures, negative, so this patient was sent home. But the IL-6 was elevated, so this patient has sterile intraamniotic inflammation, doesn't have infection, has an inflammatory process. So the patient goes home, and after the patient goes home, she comes back 2 weeks later, and this is what happens. The membranes are prolapsed into the vagina, no longer a short cervix, and the patient has developed sludge. The patient doesn't want a repeat amniocentesis, and we give her these 3 antibiotics. When the patient was admitted, C-reactive protein was elevated. We began antibiotics. CRP went up, but eventually the CRP went down below normal range. When the patient was 11 days in the hospital, she said, I don't have any symptoms. I want to go home. She basically disconnected her IV and decided to go home. I hope that we're not the only ones who have this patient at the PRV. I'm sure you have these patients also in Asia. Well, 3 days after discontinuation of the antibiotics, remember that this patient had bulgy memories. Here is the cervix. We now have a cervix that is 21 millimeters and mild funneling. Funneling is not important as far as I'm concerned. There is a little bit of sludge, but the patient decided that with this she was going to go home. And now she is 36 weeks of gestation. She is a child. This is a very long cervix. There is no amniotic fluid sludge. The patient delivered via C-section or obstetrical indication, and these are the memories. Memories are clear. Here is the amnion. There is no evidence of inflammation. So antimicrobial agents were successful in eradicating sludge, in restoring the cervix. And I want to emphasize that we did not place a sludge in this patient. So cervical insufficiency that was heralded by a short cervix, and the patient had eradication of the sterile intramyotic inflammatory process and an liver. So the take-home message is here you have sludge with acute cervical insufficiency and with antibiotics, this patient delivered a term. I want to be clear that some patients continue to have a dilated cervix, and we have placed cerclages after we have treated the intramyotic inflammatory process. Now, many people have asked me, do we need to perform amniocentesis? Why don't we just treat everybody with antibiotics? Well, unfortunately, not all patients with sludge have inflammation, and I wish that ultrasound could diagnose the species of bacteria that we have in the amniotic fluid, but it doesn't. Some patients have viral infections with sludge. Some patients have fungal infections with sludge. Now, and for example, there are publications in which we have candida in the amniotic fluid, and the combination of antimicrobial agents that I show you is not going to treat candida or virus. Now, to close, what happened? This is not sludge. I'm going to show you this case that Pia did in her university. It's a patient who presents at 30 years of age. BMI, she was thin. She had a threatened miscarriage with subchorionic hemorrhage, the most common complication of pregnancy, and she had recurrent vaginal bleeding during pregnancy. And this is the first picture that I show you. But this is not typical sludge. It's particulate matter in the entire amniotic cavity. And even this particulate matter was swallowed by the baby, and you can see it here in the stomach. So here is what happened, 23 weeks of gestation. You can see the particulate matter without funnel, and here is the cervix. And here is the particulate matter everywhere. Well, the patient had a short cervix, so she was given progesterone. Look at the funneling over here, and look at the sludge, beautiful sludge. There was a subchorionic hematoma, and I think that that is a problem because that is accumulation of blood outside the membranes. And at 24 weeks of gestation, there is amniotic fluid, particulate matter, subchorionic hemorrhage, and amniocentesis is performed, and this is the color of amniotic fluid. By the way, that doesn't look like inflammation. It looks to me like meconium. And it looks like meconium because when you have blood in the amniotic cavity, the catabolism of heme is towards the formation of bilirubin. And this is the color. Now this patient had a normal glucose, but the amniotic fluid white blood cell count was elevated, so she had intramyotic inflammation. She had no organisms, There were red blood cells, and there was an elevated IL-6. The IL-6 should be less than 2.2. So the patient had an elevated white blood cell count, an elevated IL-6, so she had intraamniotic inflammation. This patient was given antibiotics because she seemed to have inflammation, but I want to emphasize to you that this patient had occult blood that can be diagnosed just with a simple chemistry of the amniotic fluid, and also via the spectrophotometry of amniotic fluid with delta 450. Now, the follow-up is that the patient had ruptured memories. There was expected management despite of antibiotics. In day 6, there was a persistent fetal tachycardia, and here with this fetal tachycardia, a cesarean section was performed because of a non-reassuring fetal heart. This is PS case, cesarean section is performed, and look at what comes out. Let's look to the left. Well, look at the color of the fluid. So with intraocular amniocentesis, this is very at a normal pH. So this has nothing to do with the baby didn't have inflammation. There was hemoglobin, all the red hemoglobin in the amniotic fluid. Examination cell pellet showed that there were squamous cells, but all of this is blood that was in the amniotic cavity, just in case you thought it was meconic. This was then amniotic fluid particulate matter that was attributed to the presence of blood in the amniotic cavity. So I have told you, sludge is important, is frequent. In order to diagnose the cause sludge, we need to analyze amniotic fluid. And yes, you can successfully treat intraamniotic inflammation due to infection or intraamniotic, sterile intraamniotic inflammation. With that, thank you very much for your attention. If there are questions, I'll be happy to answer.
Thank you, Professor. I don't think we have some question, but this is very inspiring talk. So let's move on to the next topic. This is about the preterm birth prevention clinic, a Hong Kong experience by Associate Professor Annie Hui from the Chinese University of Hong Kong. Please give her a very warm welcome.